Numbness and tingling may actually be painful, and then paralysis usually follows in the extremities. Reduced muscle tone and lack of reflexes are a common, persistent problem. The loss of sensory is pretty variable. And it seems that deep sensation is more affected than superficial sensation. In patients who have severe dysfunction, severe muscle involvement, respiratory muscle paralysis, they may also develop autonomic nervous system, both sympathetic branch and parasympathetic branch dysfunction. It's not always, this doesn't always happen, but if, in the severest cases, you may end up with autonomic nervous system dysfunction. And your autonomic nervous system is responsible for innervating your peripheral nerves to increase muscle tone around. And when I say muscle tone, I'm meaning the muscles on the blood vessels, actually, so that when you get up, the blood vessel tone increases and keeps your blood from dropping to your feet. You know, when that's not working right, you end up with orthostatic hypotension if your blood vessels don't constrict like they're supposed to in response to movement. Sometimes these patients will have hypertension. They'll have very abnormal vagal responses. They may have bowel and bladder issues, facial flushing, and diaphoresis. The abnormal vagal responses might be things like, well, just think about what happens if you stimulate the vagus nerve. It slows your heart rate, can cause a heart block, can even cause asystole, which is not a good thing. If the patient dies of Guillain-Barré, it'll be because of autonomic nervous system dysfunction or because of some complication of immobility, not because of any of the nerve sensation or nerve paralysis symptoms. Remember that with adequate support, 85 to 95% of patients will recover completely. Sometimes, again, not often, you may have progression that involves the lower brainstem, involving cranial nerves 7, 6, 3, 12, 5, and 10. You all know what those are. You know, 7 is your facial. 6 is has to do with some eye movement. So does 3. 12 is the hypoglossal. That's muscles of the tongue. And then, of course, 5 is your trigeminal. And 10 is your vagus. And so if there's any of these lower brainstem nerve involvements, the patient may have some facial weakness or some extraocular eye movement difficulties, or they may have some paresthesias of the face. Guillain-Barré sometimes produces pain, including paresthesias, muscle aches, or hyperesthesia, and there should be a Y in there, and I probably get one into your, I haven't done your video, your PowerPoints yet. I'll try to remember to fix that. Complications of Guillain-Barré include respiratory failure because of the ascending paralysis. So it would be really important to continue ongoing assessments of respiratory function. And then the complications of immobility are identified here for you. You should all know these. This should have been taught in fundamentals. It should have been reinforced in AC1. It is what so much of our nursing care is focusing on preventing complications of immobility. And with Guillain-Barré, the paralysis certainly causes immobility issues. Collaborative care. Ventilatory support if needed. Okay, sometimes the paralysis does not move all the way up to involve the nerves of respirations, but it may certainly. and the patient may need ventilator to breathe. Now, if treated within the first 2 weeks with plasma exchange, there is a distinct reduction in the length of hospital stay, the length of time a patient's on the ventilator, and the time required to resume walking. So plasma exchange within the first 2 weeks is ideal, but it may be done in the first 2 to 4. Seeing my little typos there. Immunoglobulin is as effective as a plasma exchange. It is immediately available and it's safer, but in order to get immunoglobulin, a patient has to be well hydrated and they have to have good kidney function. After 3 weeks, the plasma exchange and immunoglobulin therapies really don't have that much value. It's real important to get that in early. Corticosteroids do not seem to have any effect on prognosis or duration of disease. Difficulty swallowing, if there's some cranial nerve involvement, may produce aspiration risk, and the patient may have to, flex their head forward during swallowing, those things that we teach in swallowing when there's an aspiration risk. Tube feedings may be necessary. If the patient has a paralytic ileus, they may require TPN. Motor paralysis and weakness are going to affect their ability to take care of themselves, and we need to focus on complications of immobility. I just realized I went over 10 minutes. I hope this takes. We'll see.